Time and for today's presentation. There will be a question and answer period at the end of the presentation, but you can also type in your questions in the chat if you would like. So thank you very much to both of you, and by all means, the floor is yours.
All right, thank you so much for that introduction, Diane. I am going to start sharing my slides. And don't feel bad about the NASH acronym. It is easily, I fumble on it all the time too. It's a very long disease name. Okay, so to kick things off, thank you again for the opportunity to present to you today. Just to say it again, but my name is Rami Halabi. I am a medical science liaison with Novo Nordisk, and today I'm actually presenting on the chronicity of obesity, and we're going to go a little bit deeper and explore the underlying pathophysiology behind obesity. Okay, so on today's agenda, I'm going to be speaking about, why obesity is classified as a chronic disease, what the impact of obesity and weight loss is on our health. We're going to discuss a little bit about the clinical practice guidelines, which are the tools that healthcare professionals and patients can use to manage obesity here in Canada, and then explore a little bit more in depth on one of the emerging treatments in obesity care, semaglutide. And then our second speaker today, Kanza, will be presenting on the benefit plan updates. Okay, just to start off, so we're going to be focusing on obesity as a chronic disease. So what is obesity? So let's clarify what the definition is. So obesity is a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal or excessive body fat that impairs health. Quite a big definition, and we're going to break down these different components here. But things I want you to keep in mind is that it's progressive, it's relapsing, and it's excessive body fat that it can impair health. And this is the definition we use in Canada, but it's not unique to Canada alone. In fact, worldwide, we see relevant organizations have all issued statements very similar to this definition, classifying obesity as a chronic disease, a relapsing, a progressive disease, or a health risk or health issue. Essentially, and if I've listed a few of these up on here, some which you might recognize, like the World Obesity Federation, the FDA. The Defining obesity as a disease is an essential step in providing appropriate healthcare management and treatment to people living with obesity, because it's a very big step in decreasing social stigma surrounding weight-related diseases. Now, I've been talking about obesity, the definition of obesity, but how do we classify if somebody is currently living with obesity? And I hope that you're aware of how I'm using this language, but when we speak about obesity, we do speak about it in the first person. So a person living with obesity, much how you would say a person living with type 2 diabetes. The individual isn't their disease, it's something that they have alongside them. So it's them plus their condition. So how do we classify somebody living with obesity? At this point, we actually use BMI cutoffs or body mass index cutoffs equal to or greater than 30. At this point, we would say somebody is living with obesity. Now, how do you calculate BMI? Very easily. You could do it right now if you have a calculator on hand, is you take your weight in kilograms and divide it by your height in meters squared and square that. Or sorry, your height in meters and square that. So this is easily calculated at home or in the clinic. And by this approach, you can actually subclassify obesity into 3 separate classes. So class 1 being obesity between 30 and 35, upwards of class 3, which is obesity BMI of 40 plus. Okay. Oh, This is part of it's disappeared. Apologies on that front. So in Canada, as of 2018, we knew that around 63% of individuals or adults in Canada were either living with obesity, sitting around 27%, or overweight, sitting around 36% of the population. So, I'm speaking to a group here from Ontario. Just want you to think about it for a couple of seconds. Is what do you think the rate of obesity is in Ontario? Remember, we're classifying obesity as a BMI of over 30. I'm going to show you it right now. So Ontario actually sits at the national average. So we're around 26.1% of adults are currently living with obesity in Ontario, very close to the national average of 26.8%. Okay, so now we're moving on to the impacts of obesity and weight loss on health. Question I'm going to pose to the group right now. Is obesity only a result of eating more and moving less? Is it as simple as calories in versus calories out? Well, the reality is obesity is an interplay of many different things. I'm going to use my pointer here to hopefully guide you along. We're not going to be discussing all of these in depth, but some things that I would like to highlight is that obesity, many paths can lead towards obesity. There's an interplay of all these different aspects. So if we look at the biological components, we know our brain controls eating behavior and appetite, and it's something I'm going to get into very shortly. We know there's a genetic influence of obesity. So you might be more predisposed to developing obesity. That's upwards of 70% of our 70% of our weight is dependent on our genetic makeup. We know that there are psychological distresses or stresses in general that can impact appetite and food craving control. We know our environment impacts our eating patterns and our lifestyle, what food we might have access to, and what equipment we might have access to for physical activity. Several medications are known to be more obesogenic or weight promoting. And so these might be for treatments of other conditions an individual may have, but might ultimately lead them to developing obesity as well. And then we know there are social disparities. So this is our health, our social and economic inequalities that might predispose certain people or groups of people to developing obesity. So overall, what this slide is really suggesting is that it's not simply due to an individual's choice or lack of willpower. There is going to be this interplay of many other components at the same time. And in fact, when you live with obesity, you likely also live with a number of complications that are going to target every layer of your health. If we think about the metabolic consequences of living with obesity, I've highlighted a number here. One that I'm just going to bring your attention to is type 2 diabetes. We know that your mechanical movements are impacted by obesity. So individuals living with obesity might have more severe types of asthma or chronic back pain, sleep apnea, osteoarthritis of the knee and hip. And then if we look more cerebral, more into the mental health component, we know that obesity is associated with things like depression and anxiety. So in fact, and this is a staggering number, but obesity is actually associated with over 229 complications. It impacts every single organ system in the body and touches on every single medical specialty. So every healthcare professional is likely seeing some person living with obesity and the related complications. Unfortunately, if you're living with obesity, your risk of cardiovascular disease becomes much higher. So just to orient you at what you're looking at here. So in the gray down here, we have normal weights. So these are the BMI between 22 and 25. This dotted line here suggests no increased risk. So you can see this gray dot sits on the no increased risk line. While here, these different types of categories of disease like heart failure, stroke, or coronary heart disease are listed on top. Somebody living with obesity, so here in the light green, you can see that the risk of developing coronary heart disease, stroke, and heart failure are all greater. So they are to the right of this line, suggesting much more prevalent in this population. And in fact, because of these added risks and this higher prevalence of cardiovascular disease, it has a major impact on life expectancy overall. So if we were to think of somebody with a normal BMI, so this is between that BMI of 22 and 25, we expect around 80% of these individuals to reach age 70. Now, as we increase the BMI category, let's say if we look at individuals with BMI of between 40 and 50, they only have a 50% chance of reaching age 70. So ultimately, this is a downwards trajectory. So as your BMI increases, your chance of reaching age 70 is reduced. So we've talked a little bit about, the association of obesity on our health. Now, let's pivot to how does weight loss impact our overall health? We actually know that losing weight can improve many health outcomes. We know that even losing weight up to 5%, so as low as 5%, can improve things like hypertension. But if you start increasing that magnitude of weight loss, so upwards of 15% of your total body weight, we can see things like type 2 diabetes remission or reduction in cardiovascular mortality, similar to what that slide I showed you before, or heart failure, or improvements in fatty liver. So overall, there are many health improvements that we see with different degrees of weight loss. So if weight loss is associated with all these improved outcomes, then why is it that when obesity is established, a person finds it so difficult to maintain weight loss? And so I'm going to kind of go through a phenomenon called metabolic adaptation here. So unfortunately, if somebody is currently living with obesity and begins to lose weight from something like diet, their hormones begin to change, whereby their feeling of hunger begins to increase as they reduce their body weight. Their feeling of fullness begins to reduce, so they're feeling more hungry overall. And then their metabolism ultimately goes down a little bit. And so overall, you're creating this situation where you're promoting weight regain. And this is what we call metabolic adaptation. Now, this is actually most clearly illustrated with data from the Biggest Loser competition. So if you remember this reality show, I think it was out probably a decade ago now, is when it first came out. But in this reality show, contestants were put on this 30-week, very intensive weight loss competition with really extreme diets and exercise incorporated throughout. Now, if you looked at the average weight of this cohort of individuals, so this was 14 participants were assessed in this one study, they had an average baseline body weight of 150 kilograms. And their metabolic rate, which is their resting metabolic rate, which is really the number of calories your body burns while at rest, was around 2,500 kilocalories a day. Now, after week 30, we're expecting these individuals to lose weight in this competition. And in fact, they did. They lost around almost 60 kilograms of weight by week 30. And their metabolic rate, so their actual ability to burn calories while at rest, was reduced to around 2,000 kilocalories a day. Ultimately, they're now supporting a smaller body size. So this reduction maybe makes sense, right? Now, after the competition ends, people go back to their regular routine, their regular life. And what they did was 6 years later, they called on these participants again to measure their body weights and their metabolic rates. And I'm going to show you it next, but kind of, think about what we were talking about metabolic adaptation. What would you expect to happen is essentially what happened. Around 2/3 of their body weight was regained. So individuals, despite losing 60 kilograms in that 30-week trial, ended up regaining 2/3 of it, or around 40 kilograms was regained. But their metabolic rate sat around that 2,000 kilocalories per day. So ultimately, this never increased despite, them now living in a bigger body size. So what does this mean? This was their metabolic adaptation. This meant that despite losing weight and then regaining it, they now had an overall decreased metabolism. And a decreased metabolism here meant they were burning less calories at rest, they were feeling less full and more hungry ultimately. And so these are all going to promote that weight regain. And this is that concept of metabolic adaptation. So how is this all kind of controlled on a hormonal level? It's actually all regulated through our brain. This is the main center of controlling our appetite. There are three big centers in our brain that do this. The first one is homeostatic eating. So this is where you eat for hunger. This is largely controlled by those hunger and fullness hormones that I was mentioning earlier. Adults, we do this. If we're hungry, we go and eat. But the most canonical example is actually babies, right? They'll eat when they're hungry and they don't eat when they're not hungry. And that's kind of like the end of the story with them. But if we look towards hedonic eating, and this is kind of where majority of adults sit, is this is where we eat for pleasure because we want some form of food, or it's because we're in a social setting where there is food. And this is controlled by things like your dopamine and your cannabinoid signaling systems in the brain. That they control the wanting of food or the liking or the enjoyment behind food. Now, that's all great. Maybe there is a donut in the lunchroom today and you're interested in eating it. That's your hedonic center kind of getting really activated. It really wants it. It really likes it. And you eat one of those donuts. How do you stop yourself from eating a second donut? Well, that's actually your executive function. This is your ability to decide what to eat. This is a big center that kind of puts the stop or the go signals to all this type of eating. And you can imagine people living with obesity might have changes in any one of these areas that can actually impair their appetite regulation and food craving control. So overall, this is to say that, obesity is not simply due to an individual's choice or lack of willpower. It is all of this kind of combined. We focused a lot more on the biological component here today of how eating behavior and appetite can impact um, weight regain or disposition to weight regain. So many paths can lead to obesity, and with that, I'm going to discuss what we have in place in Canada. So in Canada, our healthcare professionals are actually equipped with clinical practice guidelines on the management of obesity. You can kind of think of these as blueprints for medical management, ultimately. These guidelines have been very well received internationally, that actually both Ireland and Chile have adopted them as their own national obesity guidelines. And the Obesity Society of the USA has recently formally endorsed them. So, quite big news for Canada with their with this big guideline that was most, the big update happened in 2020, but since then it has had a few iterations as the data has changed and new pharmacotherapies have been incorporated. So in these guidelines, healthcare are asked to go through a number of different diagnoses or different assessments with their patients. So I'm not going to go over all of these, but ultimately there is a checklist that all healthcare professionals should engage with their patient. But one of the main things I want to point out is it asks the healthcare professional to address the root cause of obesity, because as we talked about it, there are different paths that can lead to obesity. An individual that has a genetic predisposition for obesity is going to need different treatment than somebody that has an environmental disposition to developing obesity, right? And so this is why it's so important to address that root cause, because then we can do more patient-centric and patient-focused care. These guidelines actually touch on things like weight bias and weight stigma. So weight bias is the negative attitudes and judgments towards people living with obesity, while weight stigma are the harmful stereotypes of that we have of people living with obesity. In fact, when they did a study, assessing, reported bias and stigma, they 40% of adults reported that they were receiving weight bias and weight stigma from their family, from their employers, HR professionals, healthcare, and even amongst other people living with obesity. And unfortunately, there's pretty big consequences to having weight bias and weight stigma. It increases morbidity and mortality because it can impair somebody's psychological, psychosocial, and physical aspects to, looking for care, seeking care, or being approached for care. So, this is a very big portion of the clinical practice guidelines because it ensures that the healthcare professional is looking to provide equitable healthcare ultimately for their patient. These guidelines also talk about medical nutrition interventions, which is actually a new terminology used instead of diet, because diet almost implies, very short-lived fad. You're on it for a little bit and you're off it. While medical nutrition is actually talking about, how do you promote healthy relationships with food? How do you tailor it to the patient? And how do you ensure it makes sense for that patient's lifestyle as a whole? Because we know healthy eating is good for us. It's not necessarily something that's promoting weight loss, it's promoting overall health. And there's a chapter completely on physical activity. And this is what we would also refer to as exercise. We know that physical activity can be used as a great preventative measure for developing, excess weight. But, there's many other benefits to physical activity, and it's not necessarily weight loss driven, right? We know that engagement in physical activity can improve muscle tone and prevent things like sarcopenia and just overall health, like cardiovascular health. It can improve following physical activity. Okay, so putting it all together, there's a comprehensive approach to obesity management in these guidelines after addressing the root cause. So we know that lifestyle recommendations, so these are things like your medical nutrition and your physical activity, can achieve on average around 3 to 5% of weight loss. But that's not actually classified as a pillar in obesity management. Those are considered foundational. All individuals should be assessed or give recommendations for their physical activity and their medical nutrition with respects to their health. But the pillars of obesity management are really the big interventions that we can do that focus on things like your behavioral intervention. So this might be cognitive behavioral therapy or counseling. Again, depends on the root cause of the obesity. This might be an important avenue that should be approached with a patient. We have a pillar of pharmacotherapy. So these are the drugs that are available to individuals in Canada that can assist with weight loss on top of lifestyle recommendations. We have 4 approved in Canada, and they achieve anywhere between 3 and 15% weight loss. And then the last pillar of obesity management is your surgical intervention or your bariatric surgeries. And those can achieve anywhere between 12 and 30% of weight loss overall. So again, these pillars should be based on a patient's needs and the healthcare professionals' agreed upon goals and what their comforts are overall. So now, in the case of pharmacotherapy, if this is going to be the most appropriate pillar of choice, how does a healthcare professional and a patient kind of decide this is the avenue they want to approach following lifestyle intervention? Well, the guideline actually talks about introducing pharmacotherapy when health behavior change alone has been ineffective, insufficient, and probably more importantly, without sustained benefit. So that essentially means they haven't been able to maintain it, or there's an issue with respect to the type of medical nutrition that was introduced. Now, in Canada, like I mentioned, we have 4 Health Canada approved medications, all for the treatment of obesity, all to be used in addition to nutrition and physical activity interventions. So if we were to look at what the first medication was, which is orlistat, it saw around 3% weight loss within 1 year. That's placebo subtracted weight loss for orlistat. It is a pill formulation. Naltrexone, bupropion kind of came out a little bit later after that. It is a combo medication of 2 very well-known medications, and it achieves around 6% weight loss by 1 year. Again, a pill formulation. There is 2 GLP-1 receptor agonists represented on the guidelines, liraglutide, which is a daily injectable pharmacotherapy, which achieves around 8% weight loss by the 1 year point. And then semaglutide, which is a once weekly injectable therapy, which achieves around 15% weight loss at the 1 year mark. So just bringing this back to what I showed you earlier, we know that, depending on the magnitude of weight loss, we have different health improvements that can kind of come about it. And we know that the pharmacotherapies that currently exist really span this 0 to 15% weight loss for improvement in comorbidities. But today's talk, we're actually focusing a little bit more on semaglutide for the management of obesity. So, like I mentioned, semaglutide is an injectable therapy. It's a once weekly injectable, and on average has seen around 15% weight loss at the year mark. So semaglutide 2.4 milligrams is Health Canada approved. It goes by the brand name Wegovy, and it is indicated as an adjunct to a reduced calorie diet and an increase in physical activity. So just a reminder, it's on top of lifestyle intervention. For chronic weight management in adults with an initial BMI of at least 30, which is something we talked about earlier, which is the classification of somebody living with obesity. However, it is also indicated for individuals with BMIs greater than 27. So this would be the overweight category, providing they have one weight-related comorbidity like hypertension, type 2 diabetes, dyslipidemia, sleep apnea. And so this is the Health Canada approved label indication. So Wegovy or semaglutide 2.4 milligrams, the way it really works is by mimicking the functions of a naturally occurring hormone called GLP-1 or glucagon-like peptide 1. So normally when you eat, your GLP-1 is released in response to food, and it kind of acts like a regulator of appetite. If you remember in that slide earlier in the homeostatic eating, GLP-1s are listed there as a satiety hormone or a fullness hormone. And semaglutide mimics the function of GLP-1 by being 94% identical to human GLP-1. And it's known to have effects in the brain, regulating, food intake, so ultimately that appetite, and overall results in a weight loss effect that is likely driven by a decrease in appetite and a decrease in food intake. Now, I wanted to show you one big trial on there's been many studies of semaglutide 2.4 milligrams or Wegovy. I'm going to show you one because it really highlights the chronicity or why obesity is considered a chronic and relapsing disease. So I'm just going to orient you here as to what you're looking at. So in this trial, it was a 68-week-long trial. Around 900 participants were given semaglutide 2.4 milligrams. So in this green bar here, you can see individuals at week 0, they haven't lost any of their body weight because they haven't been initiated any treatment, but all 900 are put on SEMA 2.4 for 20 weeks. Why 20 weeks? It takes that long to reach the maximal dosing. And you can see by around week 20, individuals have lost around 11% of their body weight. Now, what's unique about this study is what they did was they took 2/3 of the individuals and let them continue on treatment. So they stayed on SEMA 2.4 for the duration of the trial, so up to week 68, while the other third of participants were pulled off the medication, basically given placebo for the remainder. And what you can see is there's a quick split of the data. So individuals here in dark blue are those that are on SEMA 2.4. We can see that they continue to lose weight up to week 68, on average losing around 17.4% of their body weight. Just to give you an idea of what that is, their baseline body weight was 107 kilos. So they're losing 17% of that. While individuals that were switched to placebo, so switched at this point here at week 20, ultimately began to regain their weight up to because they were no longer on the medication. So overall, they still had a little bit of weight loss as considering of where they had started off at, because they had lost originally 11%, but they had regained around 6% of their body weight. So they ultimately, that difference was a total of 5% weight loss overall. And this kind of highlights the relapsing nature of obesity, or the chronic nature of this condition. Is once off of pharmacotherapy, the disease kind of relapses there. Now, I mentioned categorical weight loss as being something very important, as we know that it can improve health outcomes depending on the magnitude of weight loss that we see. So thanks to the availability of these different pharmacotherapies, specifically, we're looking at semaglutide 2.4 milligrams, which you know has upwards of 15% weight loss. I have data to kind of show you how many people would, in this one specific trial, would lose these different categories of weight. So at least 86% or 86% of individuals lost at least 5% of their body weight within 1 year on SEMA 2.4. So we know that 5% is very important to target things like hyperglycemia and hypertension. We know that almost 70% of individuals lose at least 10% of their body weight, again, on SEMA 2.4, which we know is very important for things like PCOS or preventing the development of type 2 diabetes. Half of individuals lost at least 15% of their body weight, which we know is on the upper end of, improving things like type 2 diabetes remission, reducing cardiovascular mortality, improvement in osteoarthritis, fatty liver, heart failure, what have you. And in fact, we know that 32% of individuals lost more than 20% of their body weight. So again, that's not even listed here as a category, but you can imagine this kind of covers everything. So 30% of individuals are responding at the greater than 20% mark. So to summarize everything I talked about with you today, people living with obesity often face bias and stigma, which can increase morbidity and mortality. Obesity is defined as a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal body fat that impairs health. Obesity care is patient-centric. It really focuses on addressing the root cause of obesity. It moves beyond that concept of eat less and move more, and it relies on evidence-based principles of chronic disease management, similar to what you would see in any type of chronic disease management guideline. And finally, the guidelines are a tool for both your healthcare provider to provide the best standard of care, but it also allows people living with obesity to have access to evidence-based interventions and information that focus on medical nutrition, physical activity, psychological interventions, pharmacotherapy, and surgery options. So with that, I'd like to pass it off to my colleague, Kanza.
Thank you so much, Rami, for that great talk. I learn lots always, And now I'm going to switch gears to talk about benefit plans and what they've historically looked like and what is the current status of the market. Next slide. Right. So I'm not sure how many of you are aware, or maybe most of you are, that obesity historically has been excluded and not been part of standard contracts for benefit plans. Um, this started changing around 4 to 5 years ago. Um, and currently, the total coverage is estimated in the private side to be around 35%. However, this is not really reflected in the utilization of obesity pharmacotherapy. So utilization is still at around 3% of the private payer market, because a huge chunk is still on those legacy contracts, or obesity is excluded from standard contracts, and it's part of more optional benefits, or more or not part of the standard coverage that most drug therapies have for chronic conditions. Next slide. I want to give you a snapshot of what the status of a private payer carriers is as of right now. On your right side, you can see that obesity is still part of an opt-in option. So it's not part of standard contracts. Clients must request obesity pharmacotherapy to be added to their drug coverage. And on the left-hand side, obesity pharmacotherapy is part of standard contracts. So Manulife, Canada Life, and Desjardins have all kind of made obesity as part of their standard contracts for new contracts. So I want you to remember that part. But if you go down, you can see that Green Shield has made a latest change as of this year to include obesity pharmacotherapy as part of all of their contracts, which is a great and a very positive move. Next slide, please. Okay. So as of this year, effective January 1st, Green Shield has announced to make anti-obesity drug coverage to be added to standard existing benefits for all new groups, and for existing groups as of March 1st, 2023. Anti-obesity coverage would be available. This is a very positive step in the right direction to have coverage for their entire block. And we think it sets a very good precedence in terms of which way the industry needs to move towards to make first, to recognize this condition as a chronic condition that needs pharmacotherapy intervention at times, and then make the appropriate changes so the entire block has access, or appropriate access when needed. Next slide. So I wanted to wrap off in terms of going over what a typical or a optimal benefit plan could offer for obesity treatment that aligns with the 2020 Canadian clinical practice guideline. Rami went over them in detail, but I'm going to just highlight a few options that would be beneficial from a benefit plan. Basically having access to medical nutrition therapy, so having coverage to a dietitian or a nutritionist, exercise, so coverage of exercise health support, for example, a kinesiologist, psychological support, medication support when it's needed and necessary, so coverage of obesity medication, and not just coverage, but coverage on with reasonable limits. So not having coverage that allows for just one dosage of a pharmacotherapy intervention. So typically a pharmacotherapy intervention would look at around 5,000 per year annual maximum, and having those appropriate coverage in place so whoever needs that access is given those is able to get that access. And lastly, bariatric surgery. So adequate leave policies and return to work for patients who are actually lucky enough to get bariatric surgery. As you know, this is a pathway that is available but is overburdened, and most people who need bariatric surgery don't really get it at the right or appropriate time, or there's a huge delay in that process. So overall, this is what a benefit plan would look like, or a benefit plan access would look like from a holistic obesity treatment pathway. All right. With this, Rami and I are going to conclude our presentation. Thank you, everyone, for listening. I have an email address right here in case you would like to contact and have more questions, or would like to have more discussions. We did hold off asking. We did hold off questions till the end, so I'm going to open the floor to any questions that anybody might have at this point. And please feel free to reach out later as well if that's something that you would like to do.
Okay, any questions from any of our attendees for our presenters today? I guess not. Okay, well, there was an email address, and of course, you can always contact Oasis if you have any questions or any further things you would like more information on. I'd like to thank, on behalf of Oasis, I'd like to thank you both for your time and today, and for educating us on this topic, which seems to be top of mind more and more lately when working in the benefit plan. So thank you, everyone, and thank you for to all of our attendees for your time and joining us today.
Thank you.
Okay. Thanks very much, everyone. Have a wonderful day.
Thank you very much. Bye, everyone.
Okay. Bye-bye.